Welcome everyone. My name is Syed Abbas and I am a PhD candidate at the Institute of Development Studies working on public policy responses to zoonotic diseases. What this session is going to be about is to give an overview about what social determinants of health are all about. You might have heard of the term social inequalities, social determinants, multisectorality, and a lot of these are interrelated terms, and we'll spend the next 10 minutes or so to get a sense about what these discussions are all about and hopefully develop an independent perspective on it. Starting with the first question, what are social determinants of health? WHO defines social determinants of health as conditions in which people are born, grow, work, live and age, and include the widest set of forces and systems shaping the conditions of daily life. These forces and systems include economic policies and systems, development agendas, social norms, social policies, and political systems. So that mouthful of a definition really means is that our health is influenced more by our relative place in social hierarchies than merely our own individual lifestyle and health preferences. The influence upon health of non-health factors is of course not novel insight. Even amidst the squalor of Industrial Revolution era Britain, the Public Health Acts of 1848 and 1875 emphasized upon the importance of clean living conditions. The purpose was that more sanitary conditions would lead to a more productive society. A major contributor to this discourse was a historical demographer. His name is Thomas Mackune. And Mackune propounded what came to be known as Mackune's thesis on health and development. He analyzed the population growth in England from 18th century onwards. He found that England experienced a period of rapid population gain and increased life expectancy from mid-19th century onwards. That is from 1850 onwards. This is accompanied with an equally sharp fall in deaths and birth rate as well. He postulated, as you can see the graph above, is a rapid population growth accompanied by decline in birth and death rates. The reason given by Mackune explaining this phenomena was that the population growth was mostly a result of rapid declines of tuberculosis-related deaths from 1850 onwards in Britain. As some of you might be aware, most effective anti-tubercular drugs and the BCG vaccine were not adopted for about 100 more years until around 1950. So, in what came to be known as Mackune's thesis, he explained that the decline in mortality wasn't due to health advances or any public health interventions, but merely because of a better economic and living conditions of the society. That makes you think, doesn't it? Now we know that Mackune was overestimating the share of TB in mortality, and the beginning of the period was marked with increased affluence and possibly decreased infanticides, which were quite common at that time. However, Mackune's work helped initiate a debate about the overall significance of public health interventions upon influencing health outcomes vis-a-vis contributions from other sectors. By the 20th century, around this time, we know from different sources that richer and better nourished and better educated people tended to live longer and healthier lives than those less well off. Would the differences in health outcomes be still as pronounced in relatively homogeneous population groups? This was the question the Whitehall study aimed to answer, and the study was led by Sir Michael Marmot in London. Whitehall, as many of you might know, is supposed to be the seat of British government and houses many government departments and ministries. Marmot studied the health record of bureaucrats employed in different departments at Whitehall from 1967 to 69 and subsequently from 85 to 88. As all the members of the cohort would be government civil servants, they should have a guaranteed source of income and minimum standards of living. Also, as the NHS had been founded 20 years early in 1948, all the participants in the study would have received 20 years of standardized comprehensive healthcare services, thus narrowing down any further any other possible differences in the health in their early childhood. What the epidemiologists found was quite fascinating. They uncovered that despite having well-paying government jobs and having access to the same health services, and even after all other confounding factors have been controlled for, the inequalities in health outcomes still did not go away. Those working in lower ranked jobs had much worse health outcomes as measured by prevalence of cardiovascular diseases and smoking compared to their administrative superiors. The left set of columns, if you see in the graph above, show the result from 68 and the right side ones from 1988. And we find the hierarchies really prominently displayed here. One explanation given by Marmot was that those at the lower rungs of hierarchy had less agency and were less empowered to take decisions about their lives. And we find similar findings replicated in other settings as well. For example, in a survey of life expectancy and occupational class, it was found that socioeconomic status and social gradients had a very important role to play on health. Even though women in general enjoy higher life expectancies than males in most populations all over the world, we find that even this biological disadvantage can be neutralized by the effect of social inequalities. Life expectancy is shorter, and most diseases are more common further down the social ladder in each society. And what's interesting is that the health effects of these inequalities, they carry a lifelong influence on individuals. For example, take a look at this graph, which shows the risk of diabetes in men aged 64 years and above by their birth weights adjusted for BMI. And you find that those who had lower birth weights, meaning had poorer pregnancies and likely a result of poorer circumstances, tended to display higher risk of developing diabetes 64 years after they had been born. So, inequalities have a lifelong influence upon the health and how individuals live their lifestyles. So we now know that social economic factors have a big role to play in determining health outcomes. But what happens the other way around? Does health itself play any significant role in relation to social and economic possibilities and also influencing the issues of development? Some econometricians have tried to analyze the non-health benefits of vaccination, and they found that just having a simple intervention like vaccination, which definitely will lead to better health status of population, leads to benefits in other sectors as well. For example, increasing overall life expectancy is associated with increased economic growth in a society. Vaccination against measles is associated with increased average year of schooling among children. Maternal tetanus vaccination, again, is associated with increased schooling for children, even among those children whose parents do not attend school themselves. And there are multiple pathways which people have proposed, which might explain how health is associated with development. But what's important for our context is the relationship between health and development is a complex one. Likely, both influence each other using complex pathways. The effect of social inequalities is preeminent in explaining the relationship between health and development. Recognizing this, the WHO, which has been championing the cause of social determinants of health for the last 2 decades or so, came up with a landmark political declaration on social determinants of health in Rio in 2011, in which they advocated health be included in all policies. What this means is, because health outcomes are a result of interventions across multiple sectors, therefore, if you want to increase a population's health and its productivity, it is important that health benefits be incorporated in other sectors' decisions as well. Similar clarion calls to social determinants of health and addressing social inequalities have been given in Britain, in US, in the Healthy People to 2020 policy, and in other settings as well. I'm sure by now you must be as fascinated with the topic of social inequalities as I am. And if you want to read further on this, there are a couple of other readings I've included in the slide. Happy reading to all of you. All the best.